Hi everyone, welcome to another Ask the Egg Whisperer fertility Q&A series. I'm super excited to be on right now, and I have received so many email questions from you guys, so thank you for taking the time to send them in to me. And certainly I would love if you wanted to chat your question here. You can also direct message me, and next week when I do another Ask the Egg Whisperer series Q&A, I'll be sure to answer your questions. So I hope to get to all of them as soon as I can. So thank you guys for joining. I'll just wait a couple seconds for more people to join, and I hope everyone is having as peaceful a day as you possibly can. I know that being a fertility patient is one of the hardest things that a person can go through in their entire life, and certainly right now with what's going on in the world, my heart goes out to each and every one of you who are struggling to have a family, grow your family, start a family. So know that there's so many doctors just like me out there, and we're here to help you and to basically give you a roadmap for success. So don't be afraid to see one of us. You know my mantra, and that is ask more questions. And if you don't feel like you're getting the right answer, keep asking, ask someone else, and be sure to advocate for yourself. So I'm going to go ahead and, hi Amy, thank you. Blue looks great on you. Thank you very much. So I'm going to go ahead and start. I'm 33 years old. My AMH is 0.45, and I just went through my first IVF cycle. I had 6 follicles after a 12-day lupron flare protocol with 450 IUs per day of Menopur, 3 eggs retrieved. None were mature. The embryologist says she thinks that it was an egg quality issue. What are your thoughts on trying again versus moving on to donor eggs? My husband's sperm looks amazing. Okay, so here's the thing. You're 33 years old, your AMH is 0.45. Not getting a mature egg totally sucks, and it happens in about 1% of cycles for someone of that age. It is really rare and unusual. However, there are strategies that we can use as fertility doctors to get the eggs super juicy, is what I like to call them, and mature. So here are some of the strategies that I use. Strategy number 1, grow the eggs bigger. Wait until they're about 22 millimeters before you do the trigger. That actually rhymed. Bigger trigger. I'll see if I can do that again today. The other thing is use a higher dose of the trigger shot. Rather than just using maybe 5,000 units of HCG, consider 10,000 or even 15 or 20,000. And sometimes in cases like this, I'll do a dual trigger. So triggering in 2 different ways. So adding lupron as well. So by talking to the eggs in a different way, maybe we can get more eggs to mature. So those are some of the things that I do in cases like this, but I just don't like to go right to donor egg unless I have considered other opportunities to help a patient. And certainly at this age with that AMH, I still think that there would be a chance for you to get a healthy embryo without moving on to donor egg. However, if financially things are in a situation where you have a certain amount of money to spend on growing your family, then at that point it might make sense to maybe consider donor egg IVF if that is okay with you. The one thing that I'd want you to think through is this question. In 5 years, when you're 39 years old, would you ever look back and say to yourself, I wonder what would have happened if I tried again with my own eggs? If the answer is yes, try again with your own eggs. And the thing is that there's no emergency to use donor eggs. That is a bumper sticker on my car. It says there is no such thing as a donor egg emergency. I've definitely had patients who've done IVF and have had a cycle that did not work, and then we've actually taken a step back. If your husband's sperm's amazing and your fallopian tubes are open, you can consider doing IUIs. Maybe take the next 3 to 6 months, help you ovulate, have your doctor give you medications to stimulate the ovulation of more than 1 egg, and see if that would help you guys get pregnant. Okay, here's another question. But I want to go back. In your protocol, you shared that you did a lupron protocol, so obviously you have to use an antagonist protocol to use lupron as a trigger shot. Okay, here's another question. It's about alcohol and possibly destroying sperm. I hope you're having a great day so far. Thank you very much. I'm not sure if you have an article on YouTube or a video about this, but I'm wondering if during the days leading up to ovulation, the day of ovulation, or the days after ovulation, before getting your period, do you recommend avoiding alcohol consumption? I know you've talked about male partners limiting their use, but I'm wondering if there are any studies regarding women and the effect of alcohol on her ability to get pregnant or not. Does alcohol also play any significant role in destroying sperm before it meets the egg? So this is the thing. Drunk sperm can't swim straight. I hope that made you guys laugh. The reality is alcohol in moderation doesn't affect sperm, but if your partner is, let's say, dealing with other metabolic issues like obesity, high blood pressure, diabetes, high cholesterol, maybe abstain completely for the couple months leading up until that very important day, which would be your egg retrieval, IUI, or even say, look, honey, just wait until I'm pregnant and then you can go back and drink in moderation. That would be my advice there. As far as a female, or the woman drinking after IUI or ovulation, my saying is this. Are you ready? I have a saying for everything. My saying is there's no safe amount of alcohol in pregnancy. And you are poo-poo, pregnant until proven otherwise, after every ovulation in my book. We all metabolize things differently. Some alcohol for one person may not be metabolized as a little less for another person, and that can affect the embryo's development, in my opinion. So that's why I suggest not drinking after ovulation every cycle that you're trying in. Certainly you can have mocktails, and I always tell patients to maybe consider having their last hurrah to celebrate, their last day before pregnancy if you would like, but in moderation. You still want to be able to find your way to my clinic and not fall asleep before you before you take your trigger shot. That has happened before. So those are my tips as far as alcohol. So here's another question, and this is about vitamin D and vitamin D deficiency. I love listening to your podcast and I appreciate all your information. On one of your podcasts, you mentioned that autism might be associated with vitamin D deficiency. Am I correct in what I heard? If so, how much would you recommend taking? And do you have any articles that I could share with my physician? And vitamin D deficiency and its possible association with autism has been well studied in the literature for many, many years. That's why it's part of my preconception panel, and I know a lot of other doctors, they check vitamin D. My goal is a level over 40. Some people, they like the level to be above 50. I don't get too excited if the level is like 20 or anything like that, because I know vitamin D can be replaced very easily with supplements. And I recommend around 4,000 IUs per day until the vitamin D is where I want it to be. And then I reduce to about 1,000 to 2,000 IUs daily, even in pregnancy. And so my go-to supplements, especially for, let's say, a frozen embryo transfer, are prenatal vitamin D fish oil. And then you guys all know me well enough to know that I'll also add CoQ10, and then depending on your issue, I'll add some other supplements that I think could help. So yes, vitamin D deficiency has been linked in pregnancy to autism in offspring, but also the reason why it's important to me, it's also linked potentially to a higher risk of breast cancer, as well as, a higher risk of Alzheimer's and dementia. So I want all my patients to remember who I am. I don't know if I'll remember because I'll be so old. But in, let's say, 40 years from now, I would love to keep getting holiday cards, kids' birthday cards, and people remembering my name. That's supposed to be funny. Okay. Here is a great question for someone who actually likes my sense of humor. She says, I love your sense of humor and I love your Q&As. Your answers are always so insightful and more thorough. I wish you were my doctor. I wish I could be everyone's doctor, that's for sure. For today's session, I was wondering if you could talk about the need for HCG injections during the first trimester of pregnancy. My HCG is 425, 15 days after my intrauterine insemination, and my clinic has asked me to add HCG injections once every 3 days till the end of 12 weeks of pregnancy. I've never had any miscarriages. Our infertility is due to male factor. My husband has anti-sperm antibodies. They said this is routine for all patients in their clinic. I'm worried because HCG injection is classified as pregnancy category C. I'm concerned about using it in the first trimester. And can't that cause ovarian hyperstimulation syndrome? What do you say? Okay, so here's what I say. HCG is basically like taking progesterone. But honestly, if it were me, I wouldn't want to do a shot when I could do a pill. I do understand that every clinic has their own style, and in some parts of the world, and this patient isn't in the US, in some parts of the world there are certain things that are more accessible than others. And so in this part, where she's getting her care, it's not unusual for people to use HCG instead of progesterone because maybe it's more readily available or the doctor has more experience with it and they have really good success getting their patients' progesterone levels higher. And that's a really good question about OHSS and HCG shots. Certainly, taking HCG can tell your ovaries not to shrink after ovulation and can make them continue to swell. So if you've gone through an IUI cycle and you have multiple follicles that you ovulated eggs from, then certainly taking HCG shots probably doesn't make sense. But if you ovulated 1 egg or 2 eggs, HCG wouldn't cause you to develop OHSS. And you guys know me well enough to know, ask more questions. If you don't feel comfortable about something, ask, what am I taking? What are the side effects and what are the alternatives? So you really feel like you've had a really good conversation with your doctor, and you're now you've been given informed consent, and then can say you honestly know what you're taking and why. I think that's important for lots of things. So you feel like you're in control of the situation. It's less overwhelming if you know what you're taking and why. It can feel often overwhelming and anxiety producing if you're taking something and people haven't talked to you about the reasoning behind it, especially if you're going on Google and worried about things that could be pregnancy category C. Okay, so here's another great question. It starts off with their story. Our story. My husband and I have been trying to conceive for about 4 years. I'm 29 years old. My AMH is 1.7, my TSH is 1.4. When I was 13, I was diagnosed with a tumor in my left ovary and then a cyst. Since then, I've taken birth control pills to help the cyst. I stopped birth control pills 6 years ago. 2 years ago, I found out I have a retroverted uterus and fibroids, and my husband, he's older, he's 37. I hate it when people come in here at 37 and say my husband's so old, because I'm looking at them like, how old do you think I am? That's me. 37's young. My husband, on the other hand, is 37 years old. He has type 1 diabetes, and his semen results are, here we go, volume 4.5 milliliters, concentration 24 million, percent motility 58%, and normal morphology is 4%. I guess taking this into consideration, what do you recommend I do? Should I do IUI or IVF? So here's what I would say. Number 1, how many kids do you want? If the answer is just 1, maybe consider IUI. But if you've been trying already for 4 years and you're 29 years old, obviously something's wrong. Let's figure out what the diagnosis is and treat that first. And IVF sounds like it might be a better option because of the things that we're learning. If you had surgery potentially on your ovary, there's a high chance that you could have tubal blockage. So when your fallopian tubes are blocked, there's no amount of acupuncture that will fix that. There's no amount of IUI that could potentially get through that. So you guys know me, diagnosis before treatment, do an HSG, understand the tubal anatomy as much as you can. Take a look at the cavity. If you had fibroids in the walls of the uterus, make sure there isn't one inside the cavity. If your husband has a low percent morphology, look at a sperm DNA fragmentation test and then see what the results tell you. And then talk to your doctor about the fertility treatment that would be best geared for the diagnosis, and talk through what your pregnancy chances are and your family size goals. So for example, if one tube is open and one tube is blocked, you could certainly consider fertility pills with IUI with the goal of ovulating from the open side. If the sperm quality is low on the DNA fragmentation test, then see what you can do that's in your control to improve the sperm DNA. But if you feel like you've done those things and you've done everything that's in your control, IVF would be a great way to fix any egg meat sperm issue. And I call that a fertilization issue. And a fertilization issue can be because of a sperm quality issue like low morphology, an egg quality issue, or a tubal issue. So something to think about. So you can go either way. Just learn a little bit more about yourself. And you're doing all the right things. I'm proud of you. 29, I feel like young people are told, just keep trying, and that's really annoying. If you're 29, you really should be seeing a doctor to figure out what's wrong as soon as possible. Here's another question. During your session today, could you please discuss the main lupron of I just gave it away. The main purpose of lupron in an IVF cycle. So imagine, I'm trying to come up with something funny and I really can't. I can't. Well, imagine how much it would suck if you showed up for your egg retrieval and all the eggs were gone. It would totally suck. Like if you showed up and your doctor said, I'm sorry, you ovulated all your eggs. Well, that's what lupron does. Lupron prevents having a sucky day on the day of your egg retrieval. It prevents the eggs from leaving the ovary. There are different ways of starting it. There's a long lupron protocol. You start it about a week before you start your stim. There's a microdose flare protocol. You start it around the day after your period starts. I like to use ganirelix as well. So there are a bunch of different drugs that you can use to prevent the eggs from escaping the ovary. And it doesn't make sense sometimes. People are like, I don't get it. You're trying to trigger ovulation, but you're also using a medication to prevent ovulation. And I'm like, look, when you're in a car, you can push the brakes and the stop at the same time. Don't try this at home, but you really can. And that's really what we're trying to do. We're trying to mature the eggs, make sure we get them out, and make sure we don't lose the eggs and that you've ovulated. So that's the purpose of lupron. And I wish I had a funnier way of saying that. I can't think of it right now. Maybe next time. Okay, here's another question. Dr. Aimee, I'm hoping you can answer this today. That would be great. Okay, here we go. With PGS testing, so that's that's genetic testing of the embryos for those of you who don't know. I understand you can determine the gender of the embryo. Sure, we get a report back that says if an embryo is male or female. But does PGS testing harm the embryo? I understand it only samples the trophectoderm. The trophectoderm is the outer surface of the embryo. What are the odds of it damaging the embryo, and when would you not recommend PGS testing to be done? So I think it's really important. And well, here, I have a good analogy. Imagine this. You have a sick child, for example, and that child needs surgery, and you want the best of the best operating on your child, right? Well, that's an embryo. That's how I see the embryo for each and every single one of my patients. That embryo is a potential, that's a collection of very precious cells, and that could be my patient's next baby. And so I only want the best surgeons operating on that baby. And that's what an embryo biopsy is. It is a very, very technically difficult procedure that not everyone is good at. And I know that for a fact because that's, what I know. And so it's very important to talk to the center that you're working with and ask them who's going to be, my patients don't need to ask me these questions because you can assume that I've already done the asking for them. We want to make sure that the people who are doing the biopsy are technically skilled and trained. They've done enough of these procedures and they're not practicing or doing the first set of biopsies on your samples. And even if someone rolls their eyes at you when you ask these questions, that's okay. It's okay to get, it's kind of like when someone asks me, like, how will I know that this is my embryo? And I'm like, well, of course we know it's your embryo. But that's an important question to ask. So I can tell you exactly what the chain of command is from start to finish for your embryos. It's the same thing. When it comes to PGT testing, you want to make sure that you have the best of the best on your case every single time beforehand. Like, you don't want to find out later that you had someone rotating through the lab that, had just never worked there before and they had to hire in from a temp agency, for example, and they weren't used to the equipment or the biopsy technique or the laser, and that was their first time using it. So that's to answer your question. I don't think PGT damages embryos unless it's done in a way that could harm an embryo, and that could potentially be done if someone's doing the procedure that's not as skilled. Okay, moving on. Now we're going to talk about maybe sex. Probably not, but here we go. My husband and I are doing Clomid and timed intercourse. Okay, the night of the trigger, we had sex. My husband notified me that he took claritin for his allergies. Should I be concerned that this could affect his sperm? He has a normal semen analysis a few months ago. So, no, you shouldn't be concerned. Claritin actually doesn't hurt sperm. In fact, and I'm not saying this so that you try this at home, and maybe I will try this at home, but I'm not going to tell my husband I'm trying this at home. Maybe I'll give him Claritin and see. I hope he's not watching this. I swear, the things that fertility doctors do to their partners, you guys, maybe I'll do an entire show just on that. But imagine when you take something like Claritin or Benadryl, what does it do? It clears out the secretions in your lungs. Well, if you think about it, semen is like a big load of a secretion. And if it's very viscous, there is a possibility that something like Claritin, I think, might maybe make it less viscous. I don't know. It can't hurt. Maybe it will help. I mean, maybe I'm using the wrong analogy and it should be like he should probably be taking Robitussin or Mucinex. But I mean, Claritin can dry you out too. So anyways, I wouldn't worry about it if your husband has taken a Claritin. I would just worry about if your husband is taking testosterone shots and not telling you. That's really worrisome because that's like birth control pills for men. I'd worry if he's, that's pretty much the only thing I worry about. And calcium channel blockers for high blood pressure, like amlodipine as an example, that can totally block fertilization. That's another kind of birth control pill for men that I talk about with my patients. So great question. Okay, here is another question, and then I'll get to your chatted questions here in a second. What is the optimal time for trigger during a medicated IUI or timed intercourse cycle? I've heard mixed things. Should you wait until the follicle is about 20 millimeters or sooner? Okay, I do OPKs at home, and my doctor always triggers me before I reach the positive on the OPK. Does that matter? Are we just expediting what would happen anyways? Is there a way that the trigger shot could hurt success? And that's a really good question. Sometimes people trigger patients, and this does happen, so that your IUI falls on their schedule. If you know me, I'm like 7-Eleven. Maybe, is 7-Eleven open 24 hours? I'm open 24 hours though. So my point is, if you're coming in, and I am the best ovulation predictor kit, better than any clear blue, not boo, I'm better than any clear blue test, my ultrasound, my ability to check hormone levels, putting that together with your lining thickness and your OPKs, I can pretty much tell you when I think will be the best timing for your insemination. And the best timing actually is also when the sperm source is readily available and not stressed out. So there are always going to be options. So for example, if I saw a patient this morning and she had a 20 millimeter follicle and her lining was gorgeous, I would say, look, I can give you the trigger shot right now if the best timing for your IUI would be Friday late afternoon. Or I'll dispense it to you because it looks like your OPK is still negative, and we can do the IUI Saturday morning. So for me, it's always a discussion, and I still use the OPK. So for that patient that I just gave you an example of, I would tell her, look, tonight, if we chose Saturday, before you do the trigger shot, check an OPK. If your OPK is positive, I want to do your IUI tomorrow. If your OPK is negative, we're going to stay on track with the schedule. And I usually tell patients to check their OPK at 7 p.m. and then message me so that I can update them with a new plan. So that's something to consider. And don't save up sperm. Trust me, no fertility doctor likes saved up sperm. It might look great in a cup because the cup is a little bit fuller, but honestly, a teaspoon of sperm is all we need. And I feel like there should be like a teaspoon. If someone can figure out something funny that I can say there with a teaspoon of sperm, I would love that. So please send it my way. So yes, the trigger shot does matter. It helps us best time an IUI. That's what I tell patients. It is not required. I recommend it when you're doing insemination because then I know that I've timed everything right. I don't always use it because sometimes if a patient has a positive OPK and it's obvious to me that they don't need it, I skip it. And sometimes patients I have seen sadly get triggered with like follicles at like 15 millimeters. And sometimes it's because there's so many follicles, the doctor wants to prevent triplets and quadruplets. But certainly ask more questions. How many follicles am I ovulating? What are their sizes? How many are mature? When do you think my best timing should be for my IUI? Is my lining thick enough? Did you get that? Don't leave your clinic without those answers because you don't want to be confused. You don't want to be, if the cycle didn't work out, that's not the time to ask those questions. And so for me, if you're my patient, I tell you all that. I give you the pictures. I share this information with you. And then, we talk about the best timing because that's really important to me. And then here's another question. Let's see here. Should we wait for the follicles to grow before I do the trigger shot? And if your follicle is 17 and 18 and your lining is 7, if it were me, I'd probably say if your OPK is negative tonight, do the trigger shot tomorrow, one more day, let them grow to about 20 millimeters. And then lastly, we were going to do an IUI, but we're traveling when the doctor wanted it to be scheduled. My doctor said, as long as we can have intercourse, the outcome is pretty much the same. Do you agree? So I would say, if you were my patient, I would go with you. If you're flying on a private jet, I'll come. No, the reality is that, I have patients that are really excited about doing IUI, and that's awesome. I love doing treatment for patients and I love the outcomes, but I really just said that. I hate the fact that IUI pregnancy rates are so low. So guys, remember, what's my diagnosis? What's the treatment that's going to take care of this diagnosis? And what are my pregnancy chances? Super important to know before you go into it. The last thing you want to find out for you is that your fertility diagnosis makes it so that IUI treatment would be about like a 5% chance of success. That's not what you want to find out after you've gone through 3 IUIs. So typically IUI pregnancy rates for someone, let's say, who's 35 with open tubes and normal sperm, maybe 10 to 15%. The IUI part, I don't know that it really increases chances that much, but IUI is really great for people who are kind of stressed out around having sex and how to time it and when to do it. So I tell people, bring it out of the bedroom, come on over to my office, but don't have sex here. Just kidding. I don't care if you do. But right now with COVID, no one's having sex here. Trust me. I'm really funny today. Okay. Here's our next question. Thank you for your show. Super reassuring for me since trying to conceive. I'm 37 years old. My partner and I started trying to conceive last year. We got lucky within 2 months, but had a miscarriage at 11 weeks, and I'm really sorry to hear that. Since then, my periods have never been quite the same. Light and short. During my cycles, I experience period-like cramping around 6 days post-ovulation, which I find odd since my cycles are around 30 days long. After 10 months of trying, again with no luck, we consulted a fertility clinic and all the tests came back normal. FSH is 7.9, AMH 3.04. We had our first stimulated IUI this month, 2 follicles, HCG shot, estrase was given because my lining was at 6 millimeters, and now I'm taking 200 milligrams of prometrium, and I had light cramping 6 days post-ovulation. Now at 11 days post-ovulation, I'm having stronger cramping, but I don't think that the IUI worked out. I can tell because I get clear-cut symptoms when I'm pregnant, but I'd like to know if this type of cramping would be indicative of something explaining infertility. I have a retroverted uterus, so the cramps are always in my lower back. My doctor doesn't believe in testing for progesterone after ovulation. Okay, here we go. Let's break this down. At 37 years of age with 1 miscarriage, we have a really good idea as to what the diagnosis is. It sounds like there's an egg quality issue. Why? Because you're 37. You're a young, fertile woman to me. But we have to talk about, statistically speaking, what the percentage chances are for each egg to result in a healthy pregnancy with each ovulation. And so that's about 25% that an egg for a woman at 37 will be genetically normal. Compare that to someone who's 27. You're looking at an 85% chance maybe that the egg will be ovulated and genetically normal. And even at 27, the percentage rate of pregnancy is only about, let's say, 15%. So at 37, even if you ovulate a healthy egg, which is a low chance, the likelihood of that egg turning into healthy pregnancy, not because of any fault of your own, just because of one thing that we all have in common, and that's called being human, the likelihood of implantation is just so low. And then you bring in the other factor, and that's the lining. Your uterus, it's screaming at you. It's telling you a story, and it's telling your doctors, look at me. Take a look. Why is the lining thin? Is it because you might have used a drug that I hate if you've watched this show, and that's called Clomid. Clomid can seriously be an anti-fertility pill if it's causing thinning of the lining. So if that's the medication that you're taking, stop the Clomid. Next cycle, consider Femera, but also ask yourself, what's my diagnosis? And I just kind of revealed it a little bit. And how many kids do I want? And is this plan going to help me with that goal? We shout from the top of our lungs. Not we. I'm not shouting. I hope I'm not shouting. Freeze your eggs. Freeze your eggs. It's like everyone's saying freeze your eggs. But no one talks to coupled people enough about preserving embryos. And so, you guys, my egg whisperer golden rule, if you're someone who's already 37 years old and don't already have one child and want to, really consider embryo freezing. And so for this couple, it does sound like maybe doing embryo freezing would be a really good next step. Or, get pregnant with an IUI, and then as soon as you deliver, call me. And then I'll have you come here and we'll do IVF, freeze some embryos. So you don't have to worry about your fertility at 39 or 40. Because these are the conversations we want to have at 37. We don't want to have these conversations at 40 and 41, when at that point, the likelihood of having a healthy embryo is a lot lower. Okay, guys, thank you for your emailed questions. I got to as many as I could today, and any that were emailed after a certain time, I will get to next week. But I'm going to now go through all the chatted questions, and I'm going to start now. Let's see here. I'm going to start at the top, and here we go. Let's party. I'm starting IVF at the end of the month. I'm 39 years old, and I asked about freezing eggs to see how many grow well. And the doctor said if we obtain 30 eggs, we won't. So I think basically this question is 39 and freezing eggs. First of all, egg freezing is for everyone, whether you're 39 or 40, just not 50. One day, there will be a day where I'll be like, yeah, you're 50, I can freeze your eggs. But the day is not right now. Maybe when we have a new technology that can help women grow eggs. So as far as egg freezing, what I do recommend is using an egg freezing calculator that you can find online, and you just kind of plug in the number of mature eggs that your doctor thinks that they're going to get from you, and then it'll spit out like a pregnancy rate, and then you can see how many cycles you need to do for the number of eggs that your doctor predicts for you. And then after you do an egg freeze, do a post-egg freeze consult, and be sure to do it right away, like the next day. You want to ask the doctor, was there anything that they saw about my eggs that makes you concerned that maybe they're lower quality than what you expected from me? And what can I do to preserve my fertility? And you guys know the answer to that, and that is CoQ10. And you can go to the Theralogics website and use the code TUSHY, capital T, capital U, capital S, capital H, capital Y, for the PRC code discount. Okay, here's another question. I don't get progesterone supplements during my cycle. I'm currently on my 3rd round of Femara and just had an IUI. When I get my progesterone check 7 days post-ovulation, what's a good number for it? So that's a great question. So I have my goal number. You know, I've certainly had patients who are told that their numbers are low, and they're certainly amazing. So I love the progesterone to be over 10, 7 days post-ovulation. I'm super happy even with 15. I'm a little happier at 15, but I don't check. You know, checking right now, especially with what's going on with COVID, is a pain. I'm not going to say in your butt because we're not drawing blood from your butt. It's a pain in your arm. Who wants to do that extra test? So there are a couple things that you can do. Number one, you can use the PROOV test, P-R-O-O-V test.com. The other thing that you can do is just take progesterone, right? Like you guys have heard what I call progesterone, water to a marathon runner. There's no such thing as too much, and you don't want to give the marathon runner water at the end, because if it were me and I just ran a marathon and I knew that I could have gotten water the whole time, I'd be kind of annoyed, and that's to put it mildly. So I strongly suggest you just ask your doctor, just humor me. I really don't feel like getting my progesterone checked. Can you please just give me a whiff of progesterone? And there are different forms of it, and you can do progesterone capsules, vaginal applicator placed inserts. Some people actually prefer a progesterone shot in their tushy, but if it were me, I would actually take a capsule and swallow it, but every patient is different. Okay. Let's go to another question. What protocol do you use for those with adenomyosis? Is Zoladex something you would typically do prior? So Zoladex is similar to what we have in this country called lupron, and the answer is yes. So depending on the severity of depot lupron, I think that anywhere from 1 to 3 months can be really helpful. If there's any sign of endometriosis outside the uterus, for example, large cysts of endometriomas, I just gave that away. Large cysts of endometriosis called endometriomas. Sometimes there could be a benefit for removing those as well. And then definitely check the tubes, because sometimes if you have adeno, you might have a hydrosalpinx because of the endometriosis, and you might want to consider removing that before you transfer. Okay, next question. My IUI is tomorrow. My follicle is 23.4 millimeters. My lining is 9. That's awesome. When do you recommend starting progesterone? What dosage? Also, what are good sperm count motility numbers for IUI? So I would recommend around 100 to 200 milligrams per night starting 3 days after your trigger shot. If you get really symptomatic at 200 milligrams, and when I mean symptomatic, if you're like crying at everything, either stop the progesterone or reduce the dose to 100 milligrams. Progesterone can really make some people feel really, really crummy. And when you feel crummy, what I tell my patients is, look, your natural progesterones are probably just fine, and you don't need the supplementation. And if you're feeling really good on it, just stay on it. And then as far as what are good sperm count motility numbers for IUI, I mean, some people say anything greater than 5 million. My general feel is anything over 20 million with over 40% motility is a really good IUI sample. But I have definitely told a patient that, look, I don't expect this IUI to work, so just go into this realizing that the quality was pretty low. And I've been surprised. You know, I've had pregnancies from sperm that didn't look so good under the microscope before an IUI. So unless there's like no sperm or it's just twitching, sometimes IUIs can work when you don't necessarily expect it to. But the other test that I sometimes do for people, not sometimes, a lot, for people who've done, let's say, a number of IUIs that haven't been successful, even though the sperm looks great, a DNA fragmentation test can sometimes teach you more. Here is our next question. If I decide to use an egg donor, can I use one of my daughter's eggs instead of using a stranger? My daughter's 27, 24. Is that weird or inappropriate? What's your opinion on that? So I would say that every doctor is different. I feel like things have really changed a lot, especially in the last 10 years, as far as how people feel about doing things like that. And I would say it's a conversation you can have with your daughters and say something like, you guys, mom wants to have another baby. What do you guys think if I use an egg donor? And see if they volunteer. And then go from there. And certainly you have to use a psychologist. We still use an attorney to draft up a contract. And then obviously you wouldn't use their father's sperm. That's a big duh. So I personally have a very open mind about creative family building, and that's why I call it creative. And certainly it's not for everybody, but some people think that that could be a good option for them to grow their family. How many days of progesterone should one take before a frozen transfer day? Aha! So how do we know the answer to that? We have very standard recipes that we apply to most everyone. Until we had a test called the ERA test there are a couple companies that do it, but one is iGenomics. So the ERA test literally tells me what time I should start the progesterone before the transfer. I get a number, either 147, 128, 132. I think most patients on average are receptive between like 128 and 132 hours, on average. And, depending on the number of embryos you have, you can certainly just move forward with a standard protocol. And then if that protocol doesn't work, then consider the ERA test. For my patients who have worked so hard for their embryos, because my average patient is over the age of 39, I typically do the ERA test on most of my patients before we transfer. And so that's how I know how many hours of progesterone seems to be the best for my patients. Okay, here's another question. I love your approach to diagnosis. Thank you. I too wish you were my doctor. That is very sweet of you. At what percentage do you consider DNA fragmentation to be not good? And I'll tell you that. If it's between 30 and 35, I get worried. I really do. I feel like the likelihood of having healthy embryos drops significantly. And then I want to put the sperm through a sperm fitness challenge. It's easy. Keep your balls nice and cool, rule out a varicocele, check testosterone, treat it if it's low with things like Clomid or Arimidex, exercise most days of the week, sleep well, plant-based diet, be super boring, no drinking, no THC, no nicotine, like super, super boring, like so boring, you're like buzzkill now. So that's kind of what I would do if the DNA frag was high. And there are other strategies, certainly. There's Pixie, there's Zymo, you can always threaten your husband with a needle to the balls. That might get him to the gym. Well, no one's going to the gym right now, but you guys know what I mean. So certainly don't be afraid of learning more, because unlike eggs, we are born with what we have and we get what we get. With guys, there are things that are modifiable with their lifestyle that could potentially very positively, in a good way, impact sperm quality. Okay, here's the next question. Should PIO be taken in the mornings or the evenings? For those of you who don't know what PIO is, it stands for, I can't even say anything. I can't think of progesterone in oil. I was going to say pain in the, but there's no word for that starts with an O, so I can't say that. It's a big pain in your butt is what it is. And whether you do it in the morning or night just kind of depends on your doctor's protocol. And so I typically start it at night, but sometimes with the ERA test, the patients need to start it in the morning. And so you could start it morning or night, but sometimes if the ERA test tells me that it needs to be at night and the patient prefers morning, then I would start it at night until the transfer. And then after I find out they're pregnant, then one day I just have them do 2 doses and then I move to the morning or night. You see what I'm saying? Okay. I hope you can answer my question from direct messaging. I'll look at that. I sometimes worry that if I do that, I screw things up. Hi, Doc. I've often heard you say that you should know your diagnosis, but my fertility doctor thinks I'm an anomaly. See, I told you guys. I can't figure that out. Okay, so if you're an anomaly, let me tell you, you're not. Tushy method. Tubes, uterus, sperm, hormones, your genetics. There is a diagnosis for everybody. There's always an explanation. And you guys heard me talk about, maybe it's a fertilization issue. I mean, imagine this. Let's say you're 30 years old, your hormone levels are awesome, the sperm's amazing, your tubes are open. I'm not going to tell you that you have unexplained infertility. I would tell you what the possible explanations are. It could be that there's something with the outer shell of the egg not allowing the sperm in. It could be there's some sort of reaction that the sperm's not going through to get into the egg. It could be that there's some tubal motility issue, that the tube's not moving properly and the embryo can't move down the fallopian tube. There could be some sort of implantation issue due to inflammation. So I'm going to talk to you about all those things and how we're going to fix it if it is one of those things. So that's what I mean when I say I can't stand that diagnosis of unexplained. And I would hate for someone to call me an anomaly. That would be annoying. Okay, I'm trying to say, I cannot, to tap a response to show it on screen and share it with your viewers. I'm just going to read part of this here. I'm 43, AMH 0.4, FSH of 10. I had 3 failed IVFs. Now I have 1 frozen egg here in LA and 6 frozen overseas. Because of COVID, I'm thinking to use 1 frozen egg. Because I'm clearly, technically, being such a dork right now, what I'll say is, if you're 43 and you have an egg, I want you to believe that that egg is like the most precious thing, like I do, that you have. And so one thing that you could potentially do is, I have an article and it's titled Egg Thawing Party, kind of like egg freezing party, a little spin on that. And it kind of talks through the strategy that I use to prepare patients for a transfer with a frozen egg. And I do recommend, let's say, doing ERA testing, advanced sperm testing, looking at the cavity, doing preconception labs, all those kinds of things ahead of time, so you don't thaw that egg and then find out that you just missed a huge opportunity to do something ahead of time that you couldn't do, and you can't get that egg back. Okay, so here's another question. Does letrozole lower estrogen levels? And the answer is yes. That's how letrozole works. Your estrogen levels drop, then your FSH level rises, and then from there, it tells your ovary to kick out another egg. Okay, speaking of OPKs, which one do you prefer? I mean, there's so many different ones. The ones that's the least confusing for you. I mean, I'm telling you, like the solid and then the blinky smile and then the smile. I mean, it just results in so many extra office visits for me, and that's fine. I do like the tests that are the control line and then the test line, and the control line is getting darker and darker and darker until it's as dark as the test line. And I just tell my patients, just send me an email. Take a picture and send it to me twice a day if that's what you want. And I'll tell you exactly what I think, because I don't want to miss this very important moment for us, and that's called ovulation, because that sucks when a patient comes in and I'm like, oh great, you ovulated 3 days ago. And then this never happens, but I had a patient once say, well, it was Sunday. And I'm like, what do you mean? Do you not know me? You can email me anytime. After miscarriage, if the ultrasound still shows a clot in the uterus, what is the next step or procedure next? So a clot in a uterus after a miscarriage is not uncommon, and sometimes it can take 6 to 8 weeks for your period to start after that miscarriage in order to clear anything that is still in the uterus. If, however, it's been longer than that and you've already had a period, I strongly recommend talking to your doctor about a saline infusion sonogram. If it's obvious, then you can do a hysteroscopic resection of that tissue, and it may be still a little piece of pregnancy tissue in there. So do check a HCG level as well. Would you recommend going with a sperm donor that was not carrier tested for the rare genetic mutations that I unfortunately carry silently? You know, that's a tough call. I mean, I think that the chance that you and the sperm donor share the same mutation is like 1 in 500. It's really, really low. I mean, if you love this donor, and there's absolutely no way that you can, get him to be tested, I personally think it's okay, but it really just depends on your comfort level. Certainly you can have your child tested. A lot of these things are actually done as part of newborn screening at birth that we do in our carrier screen. So you'll find out at birth, but ultimately the choice is really yours. And if you're really that worried, I would say find a new donor. But if you're in love with a donor, and you know what I mean by in love with him, like, you're very excited to work with him as a donor, then I don't necessarily think that should be a deal breaker, but that's just me. Talk to your doctor. Okay, had sex, then got my positive OPK this morning, went to my doctor, and they gave me the trigger shot, doing IUI tomorrow morning. Is it bad that I had sex today? Sex is safe, sex is good, sex gets you pregnant. It is never a bad thing to have sex. I recommend sex up until when I tell you not to have sex. And for some patients, I say have sex up until the follicle check, and then I say have sex again after the follicle check. For other people, it's, depending on the situation, sometimes if there's, erection issues or, ED issues, then I change my recommendation. So I do not think that it's bad to have sex the day before the IUI. I always tell my patients, if you're in the mood, your body knows. So listen to your body and have sex. Okay, here we go. I'm 45 years old, getting ready for my second IVF cycle, and I read that prior to doing another round of IVF, you should wait 3 months, since that's the time it takes for an egg to mature. Is this advisable? And I say, heck no. If you're a patient of mine doing IVF with me over the age of even 40, I like to track and trend your follicle counts, look at your FSH level, and then pick the very best cycle to go for. The concept of waiting 3 months at 45 is like, no, please don't. Just get in there and see if your FSH level is good and your follicle count. I have a magic follicle count that I like to move forward with. I feel like if you have at least 3 follicles that could potentially grow in a cycle, if you're, let's say, 45, I would go for it. If you don't, I would say maybe regroup and think about creative family building. But I love it when women are motivated to have a baby over 45 and are successful. I haven't been as successful as I would like to be, just because it's just really hard to still have a healthy egg at that age. Okay, here's another question with blood clot disorder, Pi1, 4G, 5G. Do you change your IVF cycle? I had one kid with IUI Femera and a blood clot medication. Just wonder if with IVF we need to do something else. I mean, I give patients aspirin daily, and then in IVF, especially in the Bay Area, a lot of patients by their OBGYN are giving aspirin 81 milligrams and sometimes a higher dose, even through 36 weeks of pregnancy. So I think this is a conversation to have with your doctor, and talking thoroughly about your history, your doctor will then know if they need to do something more like add Lovenox. If you're a patient of mine, for example, who's had several miscarriages, and it doesn't have to take several for me to do this, I would add an extra blood thinner like low-dose Lovenox, but talk to your doctor about that. But I don't necessarily think that you need to do anything in addition to aspirin. Okay. I had my one-day update after IVF, 10 eggs fertilized. Is that a good number? What's the chance of getting high-grade embryos? I'm 27 and we're doing an FET with PGT. 10 eggs, 27 is awesome. I mean, anytime you get double-digit eggs, but being 27 means that your egg viability should be really good. Obviously, it's not going to be 100%, and sometimes you learn things in an IVF cycle that you didn't know until you actually went through IVF. But in general, I would expect probably 5 blastocysts for someone who's 27, and probably from 10 eggs, probably at least 3 to have normal chromosomes. So I hope for you, you see the same thing. Okay, here's another question. Is it okay to have sex at night and again in the morning when trying to conceive? Or is every 24 hours better? This is what I say. If you're in the mood to have sex and your partner wants to have sex like that and he's really enjoying it, chances are the sperm quality is going to be good. I mean, people ask me questions all the time. How often should I have sex? What position? And I always say the position that you enjoy and as often as you want. So when you're ejaculating more often, the sperm quality is better. The volume might be lower, but you don't have to worry that you're going to dry up and run out of sperm. Here's another question. Why didn't my 1 egg from my 2 follicles after it was fertilized not make it to day 5? It only made it to day 3. And that's what sucks about IVF, is like we're constantly feeling like we're losing things. And it feels like every time I call a patient, they're just like, oh my God, what is she going to tell me I lost now? And so I always frame it as what we've gained. So if, let's say you were my patient and I had 2 follicles, I would be like, oh my God, we got an egg. We gained 1 egg out of your 2 follicles. And then I would say, let's say if we got 2 eggs and 1 made it to day 5 and 1 stopped at day 3, I would be like, this is awesome. We gained a blastocyst that you've never had before. We didn't lose that day 3 embryo. That day 3 embryo just wasn't viable, and that's why it stopped growing. And certainly I know what not viable means. I know what it means under a microscope. But I know for me and my patients, an embryo for a lot of people means a pregnancy and a baby. And I get that. So that's why it's so important for me to use words that patients, I know my patients understand my words, that's not what I mean, but I'm using words so that I can make the experience for my patients better, and so they're not traumatized as they're hearing this information, because I do understand how they're viewing their embryos. And from a fertility doctor's standpoint, we think of it as like, well, the cells just aren't growing. Like, why would you be upset? But the way to think about it, if you're thinking about it empathetically, is to realize that patients aren't thinking of these cells that stop growing as dead cells. They're thinking about them differently. So anyways, I digressed. Okay, here's another great question. I'm 41 years old, 1 fallopian tube, 1 ovary. I'm starting IVF. Should I just use donor eggs instead of trying for myself? I think it just really depends on your hormone levels. If your FSH level is especially under 10, and even with 1 ovary, certainly you can have an AMH level that's over 0.6. And so if you're able to get at least, like you guys know my magic number, 3 mature eggs, I still think that there's a chance that you could have a viable pregnancy. And I want you to ask your 5-year from now self, like talk to yourself at 46 and be like, hey, 46-year-old me, would you be upset and look back and say, I wish I didn't try? But at the same time, if you've already tried a whole bunch, for those of you out there, my saying is, I want you to spend your youth, and 40s is your youth, as a parent, not a patient. So the sooner I can get my patients out of doing more IVF cycles and into changing diapers, that's my goal. So if you just look at the numbers and you're like, why would I do this to myself? I just want to move forward with an egg donor at 41. Do it. Go for it. Don't look back. Talk to a therapist. Make sure you've thought through all the scenarios for yourself so you don't look back with regret. And then make sure that if you do want a chance with your own eggs, work with a fertility doctor that has had success with patients at your age and believes in your success and your fertility. Next question. I have a day 5 and a day 3 embryo. I've had failed transfers and this is all I have left, but I'm having a hard time with the transfers emotionally. Instead of 2 transfers, would you suggest letting the day 3 grow to day 5 in the lab so I can do 1 transfer? I think that's a great question. I mean, I would totally do that. I mean, that's kind of what I would suggest as well. So thaw that day 3, let it grow to 2 days, 2 days later, and then see how you feel. If that day 3 embryo is a gorgeous day 5, why not just transfer that one and leave the day 5 frozen still? So have a decision tree set up with your doctor. If this, then that, if this, then that. Kind of like choose your own adventure. Your own adventure, not your doctor's adventure. Because if certainly that one embryo turned into healthy pregnancy, emotionally it's sometimes, I know emotionally it's hard going into transfers, but I find it's easier to go into a transfer for a patient if she knows she still has an embryo frozen, if she's not done with her family. Okay, so that's how I would think about things. So talk to your doctor about that. See if they could do that. And then if the embryo didn't grow to day 5, then definitely thaw that day 5 embryo and transfer it. And then if this is all you have, consider doing implantation testing, cavity evaluation, make sure you've done your preconception labs to make sure your thyroid is normal. You guys know the spiel. Okay, here's another great question. When do you advise taking baby aspirin before an FET? While on the day 5s, while on progesterone, before or after the actual FET, I start my aspirin with estrogen start through, again, sometimes 10 weeks of pregnancy, depending on the patient, sometimes through 36 weeks of pregnancy. How soon before starting IVF do you recommend taking the supplement soup? I don't supplement soup shame everybody, but anybody, not everybody, anybody. But my recommendation, as soon as you meet me, please start them. Start them now. And there's no, like, we don't know how long it would take for things like CoQ10 to really affect the eggs. But I've seen scenarios where I do feel like, let's say a patient did previous cycles elsewhere, and then she started her CoQ10, let's say with me, on the day of stim, I even feel like that is enough. I don't know why. Some people react to it better than others. Any special egg donor IVF prep considerations for women with premature ovarian failure? Absolutely. So if you're picking an egg donor, you want to make sure that that egg, well, as far as prep, that was the question. I won't talk through how to pick an egg donor. But the prep for an egg donor is the same prep for an embryo transfer, right? So you have your embryos created, and now you want to talk about embryo preparation. And embryo transfer preparation for me really depends on how many embryos you have frozen. So if you have 1 or 2 frozen for you, and a lot of people who use egg banks have that, seriously consider doing implantation testing ahead of time, taking a look at the cavity and all the things that I've already talked about. Exercise most days of the week, eat a healthy diet, decrease stress, consider acupuncture, and do your transfer at a time. That would be very relaxing for you. I love my mother-in-law. Some people don't. My mother-in-law is pretty awesome. She's probably watching this right now. But for some people, they tell me, my mother-in-law, she's here, she's going to be here for the 3 months. I can't handle doing my transfer when she's here. Well, guess what? Don't do it. You see what I mean? Find a time that's stress-free, and that's when I would do your transfer. Okay. Do you recommend to stop drinking coffee or tea when getting ready for IVF in September? Coffee and tea, I love my coffee. No one can take it away from me. No one can take it away from me if I were to do a transfer, and no one can take it away from me in pregnancy. Why? It improves my mood. These medications make you feel rotten. They make you feel tired. They make you feel constipated. Caffeine can help all of that in moderation. Some people say 150 milligrams. Some people say up to 300. I say 1 to 2 cups per day. Totally safe. So don't make yourself miserable if stopping caffeine will make you miserable. But at the same time, when you're pregnant, even a touch of coffee can make your heart rate shoot up. And when you're already maybe a little bit anxious because of everything you've done to get pregnant, maybe consider decaf instead of caffeinated stuff. Okay, here's another great question. Can you share possible causes of recurrent implantation failure of well-graded PGS normal embryos? Lining always looks good, trilaminar, give or take 15 millimeters. I've done ERA and receptiva, and I've had 5 embryos fail to implant. Okay, here are my thoughts. Number 1, sperm DNA fragmentation. Even though you have embryos that are absolutely gorgeous, which is what it sounds like, the sperm DNA contribution, despite having normal chromosomes, could potentially affect the implantation rate of those embryos. Number 2, I think of the egg, sperm, and uterus as 3 puzzle pieces. They may not be all fitting together. You might have a beautiful embryo, but there might be something related to implantation genes in the uterus that's not allowing the embryo to fit in quite well. Some people say this is controversial. I say this is science and we're just not ready yet for this to be prime time. but there's something called HLA-KIR, HLA-KIR testing that can be done. It isn't done routinely in this country. There are a few doctors that are doing it, like Dr. Richard Scott. There are some European IVF labs that are doing this type of testing. But at this point, if you've truly transferred the number of embryos that you say you've transferred, and I believe you don't have to prove it to me, and they're all gorgeous, and they have normal chromosomes, then something is wrong. And I would start diving deeper into what the possible causes are if you haven't already thought about this type of testing. Okay, here's another question. Do you recommend turmeric for inflammation? The answer is yes. I recommend. There's a lot of things that are great for inflammation, and turmeric is definitely one of them. So we have a patient who's saying, should I consider another cycle along with the one egg? And I would say, as long as you have eggs, for someone who's, let's say, 43, who has one follicle, and you have it in you to do another one, yes, I would talk to your doctor about whether they would still think that that makes a sense. And it would make a sense. I just said make sense as if I had an accent. Maybe to some people I do. But for one egg, the reason why I'm saying talk to your doctor is because your doctor knows what that egg looks like under a microscope. And they would tell you if it would make sense or not. Okay, here we go. My friends are on antibiotics and anti-inflammatory meds before an FET, but my RE doesn't think it's needed for me. Is that normal? Okay, guys, I have 2 minutes left, so I'm going to try and answer as many as I can in the next 2 minutes. I automatically do antibiotics and steroids for everyone. It doesn't mean that it's good for everyone or it really helps everyone. It's just something that I'm used to and something that I was trained to do. So if your doctor doesn't believe in it, I think it's probably okay, but if it's something that you really feel like you want to try, I would say do it. Next question, what does letrozole do with a protocol of 225 units of Gonal-F and 75 units of, and 75, it looks like, of Menopur? Letrozole can help grow more eggs. I use it and I call it a hybrid protocol. So I use maybe 3 to 4 tablets per day for 5 nights in combination with the gonadotropins, and that can help more eggs grow. This 43-year-old, sorry, my question cut off. Should I do another cycle at 43 with HGH along with that one frozen egg at 38? And the answer is I would strongly consider it. I'll be doing my second embryo transfer in a few weeks. How can I ensure a successful implantation? Again, think about implantation testing. Make sure your body size is perfect, that you've decreased stress, and that you're not going to be in a situation after transferring where you might be at high risk for COVID. Let's see here, you guys, there's so many questions and I feel so bad, but I'm going to try and get through as many as I can in the next 30 seconds. I have vulvodynia, so sometimes it affects my sex life. Can I get IUI done 3 times? The answer is yes, you can. I often sometimes do an IUI under anesthesia. I also have my patients take Valium to make it easy, and I also have home insemination kits for patients with vulvodynia, and you can also use medications like lidocaine on the outside to decrease pain with the procedure. I think, you guys, I'm going to stop there so I don't get cut off. Thank you guys for joining today's Ask the Egg Whisperer. I'll be back hopefully next week, and hopefully with better, funnier jokes. Thank you guys for listening. And my heart goes out to each and every one of you, and that's why I do this show, so that you can get your questions answered to know what to ask your doctors. Good night.